Why did the arm bone want to become a comedian? Because it thought it was so humorous. Oh, greetings, Dajahao, Washabao, as they say here in Suzhou, China, and a very warm welcome to the IMMT channel, where we talk about all things mind-body health related with an emphasis on Pilates, functional movement, Feldenkrais and manual therapy, because here at Sino-British Academy, that's what we do. Hello and welcome to episode 5, where today we are talking about the shoulders. How many times have you had a client walk in and you say something like, "Hey Matt, how are you today?" And they slowly point to their shoulder and say, "Oh, my shoulder hurts." Or maybe it's a new client coming to see you because his or her shoulder hurts. Now, why are they coming to see you? Either from recommendation or because they have already been through a series of rehab sessions with their physio or chiropractor or whoever. So one of the key points here is to see if we can keep away from the term rehabilitation, as this has a medical association with it, and as movement professionals, many of us are not medically trained. Sure, many physios now use Pilates and Feldenkrais as an integral part of their profession. However, for those of us without the appropriate medical training, we need to kind of stay in our own lane and be aware of our own scope of practice. So, that being said, however, as far as I'm aware, there's no reason why we can't refer to it as prehabilitation. And this concept, I think, is fairly solid. So most people wait until their shoulder is stopping them from sleeping before they do anything. And usually by then they've been to see the doctor, they've had the MRI, the CT scan, and they've got the medical diagnosis to go with it. However, the diagnosis is generally just the symptom, whilst the real story is how they got there in the first place. In other words, what is the underlying cause of the issue? And how long has it actually been there poking at the bear before the bear decides to bite somebody? So about 50% of the people walking through your door with shoulder pain have a shoulder impingement. It's the classic, "it hurts when I do this" type of thing. Then you've got your rotator cuff tears for about 20% of all problems, and the frozen shoulder accounts for about another 15%. However, granted, these conditions fall strictly into the medical category. A word of note, though, on the frozen shoulder, as this is something that commonly affects women much more than men, and usually falls into the 45 to 50-year-old age groups, and many times has a lot to do with estrogen deficiency during menopause. And diabetes or pre-diabetes is also a big red flag for a frozen or a future frozen shoulder. Quite often, there are going to be two common but opposing scenarios on getting to the pain stage. And this is going to be a lack of movement, such as sitting at a desk all day, or too much movement, which is your repetitive stress syndrome. So take swimming, for example. If all you do is the front crawl, you're bringing your shoulder into internal rotation, which is tightening the lats and the chest and severely limited the range of movement in other directions. A backstroke, however, is going to help to open these things up. So in IMMT, we acknowledge the 3 extrinsic influences and the 3 intrinsic pillars. So let's start with the extrinsic stuff. So your brain works as a filter, and it uses context to decide how much pain you're allowed to feel. Think about a professional baseball pitcher. If he feels a tiny pinch in his shoulder, his brain goes into full-blown panic mode because that pinch could mean the end of his career. But then you have the same condition and the same thing going on as you're trying to climb a tree to escape a rhino. Yep, sounds silly, doesn't it, to escape a rhino climbing a tree, but I've actually been there, so I know what that's like. This now becomes a high-stress survival situation, and you won't even notice a dislocated shoulder until the adrenaline wears off. Then you have environment. So many of our clients spend 8 hours a day or more hunched over a computer, like they're protecting an egg. The hip flexors shorten, the rib cage gets pushed forwards, and suddenly the shoulder blade has nowhere to go. It's stuck. It's like trying to open a door when there's a pile of old newspapers wedged behind it. Now, the third one is our personal belief system. So let's say you get a medical diagnosis, you see the MRI, and you are told this is the problem. So now you start guarding. Now you get reduced to two possible options. Either don't move or boom, train through the pain. So if so, then you're just exhausting your physical reserves and making the impingement worse. Hello, all you triathletes out there. So now, how about our 3 intrinsic pillars? So first is the structure and function. If you can't breathe properly, your shoulder is buggered. Simple as that. If your rib cage doesn't expand, your shoulder blade doesn't have a stable base. It's got nothing to sit on. It's like trying to set off fireworks from a bouncy castle. This could commonly lead to the classic upper crust syndrome with your tight chest, upper shoulders, and weak lower traps and neck flexors, all helping to push the head forward and the head of the humerus nicely forward into that classic anterior position where it completely loses centration. Next up is the nutrition. So tendons have a poor blood supply. They need hydration and omega-3s to keep the synovial fluid from turning into sludge. Added to this is enemy number 1, sugar. High blood sugar leads to glycation, where sugar molecules actually bind to the collagen and chemically stiffen your joints. And our third intrinsic pillar is the emotional component. So the brain uses the same neural circuitry for physical pain and emotional pain. So if you're carrying the weight of the world on your shoulders, your body literally takes that. Many stress conditions can lead to variations of the startle reflex, that classic position in that infamous picture of the guy with there's a gun being held close to his head. And once you see that, you can't unsee it. So it could well be that you are hunched over with your shoulders up and shoulders rounded, neck extended, head forwards, and locking your joints in a compromised position because you're stressed about your mortgage or your cat's dental bill. The emotional component also takes into account the ability to process information through the sensation, perception, appraisal route from the thalamus to the amygdala. Okay, imagine you're walking through the garden and the grass is long and you suddenly see this. You've got 1 second to look at the picture. What did you see? Okay, so first comes the raw data or the sensation. Secondly, the thalamus forwards this raw data of what you've just seen to the sensory cortices, like the visual cortex at the back of the head, where the brain now automatically compares this incoming shape to your past memories, schemas, mental maps to figure out what it is that you're looking at. Your brain then decodes that shape, which is the perception part. So in this example, probably what happened to most of you is your visual cortex decoded the shape, connected it to a memory, and recognized the pattern. Oh, that's a snake. Then comes the appraisal part. So your amygdala now has to make a threat assessment. And for that, we have a fast track and a smart track. So in the fast track, the information from the thalamus reaches the amygdala before the perception part has finished. And in this example, the response was probably snake, equals danger. So to keep you alive, there's a preemptive threat response before you even consciously realize why. However, if the cortex recognizes the shape as the garden hose you left out yesterday, then this information arrives fractions of a second later, and that threat response is now dampened. Well, what's this got to do with shoulder pain, I hear you say? Well, if your brain registers a physical sensation in your shoulder joint, the sensation part, it internalizes and decodes it as a structural pinch. That's the perception part. And then your personal belief system will dictate the threat assessment part. So if you grew up in a house where your dad is a snake charmer, your threat assessment would be relatively low. However, if your parents jump around like cats on a hot tin roof every time they see something slither, your threat assessment is going to go through the roof. Likewise, if you believe your shoulder is structurally fragile, the amygdala treats that pinch as a massive threat, instantly triggering systemic cortisol, muscle guarding, and localized pain amplification. Okay, so now we got that out of the way, the question becomes, what can we do as movement teachers? Well, the first thing is to recognize that, in fact, that there may be something going on other than what you see in the imaging report or even in the posture of the person in front of you. So as movement teachers, we can start with some form of visual or tactile assessment. And this is going to include the biggie to start with, which is breathing. So first of all, are they a chest breather? Then you're going to be looking for that forward shifted rib cage, which compromises that scapular stability, and the scapular shoulder blades have nowhere to sit now. Then we can look at the scapular movement itself. So we need to check for the adequate range of motion in all planes, such as the depression elevation, upwards and downwards rotation, posterior tilting, and the two biggies of protraction and retraction. We can check for the humeral position, looking for that habitual internal rotation or an inability to externally rotate during overhead movements. Palpating the sternoclavicular joint is a biggie. This is a critical area for the shoulder girdle function. It has the fascial connections of the clavipectoral and Simpson's fascia, neurological switching, and lymphatic drainage. So if the sternoclavicular joint is stuck, nothing else is going to work efficiently, and you're just polishing brass on the Titanic. And of course, we need to check the rib cage. Feel for the ribs that may have translated, if you have these skills. A rib translated laterally will have an anterior rotation compromising both the inhalation and elevation of the arm. We can also check the latissimus dorsi, assessing for tightness, which can create that dislocated effect on the glenohumeral joint. And after assessment, we can think about what to do for our intervention strategies. For breathing, crocodile breathing is a great start. For that, lie on your belly to encourage breathing into your back, trying to get that rib cage to move. It also calms the nervous system down and helps to tell the amygdala to stop screaming about snakes. 90-90 breathing is also a good one to encourage breath into the lower posterior portion of the rib cage. And this area is very often stuck with an anterior rib cage position, which also glues the lats and restricts this anterior protraction movement of the elbow. Utilizing hypopressive breathing can be very useful here if you know how to do it. Next up is the mobilization. So muscle energy techniques are great, safe and efficient techniques to restore glenohumeral joint centration and to help mobilize the first rib and T1, T2 vertebra. Also, if it's in your toolbox, you can apply some soft tissue techniques such as the structural integration, fascial release, stecco, fascial manipulation, strain counter strain, and intercostal reset. These are all great methods to help release the intercostals, the pec minor, and even the interosseous membrane in the forearm. Yes, the forearm. Everything is connected. If the wrist is tight, the shoulder is going to feel it. We can move now on to activation and focus on strengthening the weak stabilizers. So these are especially going to be the lower traps, the rhomboids, and the serratus anterior. Most people's serratus anterior is about as active as a teenager on a Sunday morning. And trust me, I got a teenager. So we need to wake it up. The Pilates equipment offers numerous ways to get that pesky serratus active again. So here you can see me working on the trap table with the push-through bar to help activate and release both the serratus anterior and the rhomboids. The lower traps are also one of the biggies we need to activate as well. The Pilates equipment and any light pulley system and the prone position are excellent for this, as you can see here with me working with Dawn. Okay, so after all that, what's the takeaway for today? Well, certainly in the case of the shoulder, it's about stop chasing the pain. The pain is just the brain's way of saying, I'm unhappy. Look at the structure, look at the nutrition, look at the stress, and more critically, look at the breathing and look at the rib cage. And of course, if you see a hose in the garden, don't jump. It's just a hose. Unless it's a snake. So that's about it for this episode, folks. I hope you enjoyed my ramble for today. I look forward to seeing you in the next episode where we will be talking about those cursed hip flexors. So until then, be good. And if you can't be good, be careful. Bye.